So, I mean, it's my real pleasure to introduce today Dame Lesley Fallowfield. Now, she's a professor of psycho-oncology at Brighton and Sussex Medical School. And she's been doing a lot of work on the psychosocial oncology aspects that patients deal with. She's got extensive research publications, and she has research interests far wider than that as well. Today, I think in terms of imagers who are predominantly the people involved with NCTA, we have a whole set of imaging trials which we want to set up and get running. But we often, I think, underplay the importance of patients within those trials. And so it's really nice to hear from an expert in the field about how patients and clinical trials go together and the interactions that are important within that. So thank you all for coming, and I'll hand you over to Professor Fallowfield.
Thank you very much, Shane. So if I can just get onto my screen and share it with you. Great. Okay, so I'm very pleased to be giving this talk. I feel quite honoured. And when I was invited, I was asked to talk about sad, bad, and just plain complex things, but with a particular emphasis on trials. And I've had quite a long career in this area, probably spanning about 40 years, which I suspect is longer than some of the people listening have even lived. Anyhow, anyone who achieves anything only does so because of the people who've done sterling work, who've gone before, or the people who have encouraged and mentored them. So this is going to be a very personal perspective about some work that I've actually only achieved because of two people in particular who I'll talk about in a moment. But before I do that, I have to also acknowledge my team at SHOREC, which stands for Sussex Health Outcomes Research and Education in Cancer. And that's what we do. We do a lot of work in clinical trials. We develop patient-reported outcome measures. We evaluate ameliorative interventions to help patients deal with the worst side effects. And importantly, as you'll see later in the talk, we do a lot of work on helping to educate healthcare professionals in how best to talk about the complexities of modern cancer care. So I can just move on. The shoulders that I've stood upon. Two people here who some of you may recognise, Professor Michael Baum and Professor Robert Suhami, and you'll see why I owe so much to both of those men. Now, I guess certainly in the time I've been working in the area, cancer has just become so complicated. The better understanding that we now have of genetics, the underlying molecular biology of cancer has facilitated lots and lots of important therapeutic advances. We've got better diagnostics, improved surgical and radiotherapy techniques, and targeted systemic treatments now mean that many of our patients not only survive for longer, but also many of them survive with a better quality of life. But the downside, if there is one, is that cancer and its treatment is no longer simple to explain. And patients who are already experiencing emotional turmoil enter this very strange new world with esoteric language and concepts. Let me give you an example from breast cancer. When is negative positive and positive negative? In lay terminology, of course, positive is good, whereas negative is bad. But positive lymph nodes are pretty negative. ER and PR positive tumours are positive because they're favourable in terms of prognosis, and also there are good treatments available. HER2 positivity can be more negative and very negative if patients are not given the appropriate targeted therapy. And conveying just how negative triple negative breast cancer is, with no clear treatment guidelines, the aggressive nature of it in a positive manner is very tricky. Now, there are loads and loads of benefits of good communication. We know it improves the history taking, helps patients to say what their primary problems are. It affects adherence to lifestyle changes as well as treatment. It influences the emotional and the physical well-being of patients, improves their overall experience of care, and it reduces the risk of litigation and medical complaints. And we know from other work that's been done over the last decade that good communicators don't experience the same degree of burnout that you see in many healthcare professionals. Now, in cancer, there are many sad, bad, and just plain difficult areas, which I've listed here. The diagnosis and prognosis, describing complex test treatments, talking about trials and randomization, handling distressed patients and relatives. I could go on and on and on, but we're going to focus predominantly today on talking about clinical trials and randomization. Now, I started in this area, I told you I'm very old, in 1984, when I went to join Mike Baum at the CRC Clinical Trials Centre at King's. Now, during that time, in most of the cancer centres, mastectomy was still the primary surgical treatment. And things like breast conserving surgery, lumpectomy, wide local excision, were still considered by many people to be somewhat heretical. The terms psycho-oncology, quality of life, rarely were used in talks, papers, or even measured in trials. In fact, in 1984, there were only 8 publications I could find that had quality of life and cancer in their title. Now, Mike employed me to do to take part in a randomized trial of mastectomy versus breast conservation. It was dubbed the trial that everyone needed, but nobody wanted. Patients with early breast cancer and no clear surgical treatment preference were randomized to either mastectomy or breast conservation. The primary aim was to see that lumpectomy, lesser surgery, would be safe, and also test the assumption that it wouldn't actually produce the unremitting psychological morbidity that had become associated with mastectomy. The trial itself failed to recruit for many reasons, but a small psychosocial study was completed. We published this in the BMJ, and essentially what we found, as you can see here, mastectomy patients and breast conserved patients, they experienced virtually the same degrees of psychological morbidity and loss of libido. There was no difference between groups in either of those things. And importantly, as we'll see later, more than half complained that communication about the trial had been inadequate. Now, challenging any orthodoxy is never going to make you many friends. The small study we published received widespread publicity, but it was heavily criticized because people thought it was counterintuitive. Surely, not removing somebody's breast would make them feel so much better in so many ways. They claimed that as the women who were prepared to be randomized, not to choose their treatment, they couldn't be a typical population. And that lots of people suggested that if only you gave women choice, most would definitely opt for breast conservation and the psychosocial benefits then would be obvious. Well, Mike and I don't like just people saying that they don't like something because it actually goes against what popular myth would have. So we actually developed the choice study. This was a prospective multi-center study capitalizing on the individual and motivational differences of both patients and their surgeons for different management policies. 269 women with early breast cancer who'd been referred to 22 different surgeons in 12 UK hospitals took part. The patients had their surgery, radiotherapy and chemotherapy, and those who were premenopausal had tamoxifen. Anxiety and depression was assessed using standardized methods preoperatively at 2 weeks, 3, 12, 24, and 36 months post-surgery. Again, we published these data in the BMJ, and you can see here that we had surgeons who favoured predominantly mastectomy, and they recruited 30 patients. Surgeons who favoured breast conservation wherever possible, and that was 121 patients, and surgeons who felt they always offered women the choice. They recruited 118 patients. Now, what was quite interesting was that even in the breast conserve favouring surgeons, as well as the choice surgeons, many of them ended up doing mastectomies on patients. This was usually due to technical reasons, you know, a central lump in a small breast, for example. And only 62 of those 118 women in the choice group were actually able to choose, again, usually because of some sort of technical issues. And when they did choose, a third chose mastectomy and 2/3 breast conserving surgery. So what about anxiety and depression? I'm just going to show you the data from 12 months. There was no significant difference again between breast conservation or mastectomy. But what about the feature of choice? What was the effect of surgeon type? Again, we published this ages ago in the BMJ. Women who were seen by the choice surgeons had less morbidity, psychological morbidity, than other groups. And this difference was still apparent at 24 and at 36 months. But as you can see, there was no significant difference in psychological morbidity, either between treatments or between those who had a real choice and those who could not choose. So what's going on here? Well, it had everything to do with communication and adjustment. The women who perceived their information as having been good were less likely to be anxious and or depressed at 12, 24, and 36 months. They appreciated the fact that the choice surgeons in particular were much better at communicating with them the logic, the rationale for one suggestion rather than another. So the choice surgeons generally were better communicators, and the desire for autonomy about what operation to have was less strong than the need for clear and accurate information and about sort of the logic for which treatment would be better recommended by people. So perception of information at diagnosis, those who thought it was good had less anxiety and depression than those that thought it was inadequate. So communication in breast cancer. Well, the period between being diagnosed and treatment is stressful, and there are lots of time pressures to make quite quick decisions, and any emotional reactions that women have can hamper their cognitive reasoning. Educated choices demand that they have to absorb vast amounts of clear information. And one of the things we see in cancer generally, not just breast cancer, is that in the context of life threat, there's an assumption that more aggressive treatment is better than less. And I think ambiguous, diffident communication will feed into that myth. So on top of all this, adding discussions about clinical trials can complicate things further. Now, I've entitled this slide, Escalate when necessary, but de-escalate whenever possible. That's what's happening at the moment in surgery and also actually with systemic treatments as well. I think Mike Baum made huge contributions to breast cancer clinical trials in establishing the safety, reducing the harms of different surgical treatments, and improving patients' quality of life as a result. My own group over the years have been involved in several de-escalation trials in breast cancer, such as Almanac, looking at sentinel node biopsy, the POSNOC trial, looking at axillary clearance or radiotherapy, the Target trial, looking at intraoperative radiotherapy, and the Loris low-risk DCIS trial, comparing surgery or active monitoring. And I just want to say a few words about that, because I think this issue about de-escalation trials are problematic for patients with life-threatening disease. The scientific logic for all de-escalation trials is obvious to us as scientists, but tricky for patients to understand. I mean, let's look, for example, at what's in a name, discussing ductal carcinoma in situ with patients. It's a difficult condition to describe, and there are a variety of controversial opinions about whether or not it should be really described as cancer at all. We don't know about the natural history of it. It could even be a technology-created, screen-detected disease. It's described variously as precancerous, pre-invasive, non-invasive, or intraductal breast cancer. And certainly the incidence has increased significantly since the NHS breast screening programme started, representing about 1/5 of all screen-detected cancers. And reviews show that some women with screen-detected lesions might well be being overtreated. The DCIS, especially if it was low grade and very localized, might never have developed into full-blown invasive cancer. And as I said, as natural history is lacking, low-grade DCIS is nearly always treated as if it is invasive cancer. Now, the Loris trial had many drivers and barriers to participation. We know the scientific question was important and the logic for a proper randomized trial persuasive, but this wasn't always as compelling for individual women and members of MDTs. Loris was what we describe as a hard to recruit to trial, rather like that original mastectomy versus lumpectomy study, as there's a powerful perception of benefit from catching it early, which is often conveyed to patients, and getting rid of as much of it as possible. Labeling something possibly indolent as cancer or even carcinoma in situ, as the title suggests, incurs fear that fuels a need for action, usually surgery. And the use of cancer or carcinoma might have scared women into refusal of the trial and or randomization. So the Loris trial will be reporting some of the patients that it recruited to it. We certainly never got the thousands we had hoped for worldwide, but I think it was something to do with the name, as well as the fact that patients were being randomized to either surveillance or active surgery. So I'd like to move on now and talk a little bit more about decision making about trial entry. And my next giant, whose shoulders I'm standing on, is Professor Robert Suhami. Now, he encouraged me and my research team to move to the Department of Oncology at UCL. We were then called the CRC Communication and Counselling Research Centre. Bob is another very inspiring, witty, eclectic individual with a passion for clinical trials and also good communication. He did a lot of work encouraging my team's research into understanding about randomization, the reasons why patients would join trials, and the development, importantly, of educational programs for healthcare professionals trying to recruit patients to studies. So the first study that we did with Bob was looking at the attitudes of patients to randomization. As most of you listening to this talk will know, worldwide, far too few potentially eligible patients ever get entered into trials, and this impedes the introduction of important novel therapies into clinics. Now, there are lots of reasons for recruitment difficulties, including the information and communication provision, but we designed a short questionnaire to try and identify the issues that patients might have specifically about different types of information they needed about a randomized trial. And we then went on, and I'll talk about that in a moment, and looked at the ways doctors discuss trials with their patients. So here is a paper, Attitudes of Patients to Randomized Trials of Cancer Therapy. We designed something called the Attitudes to Trials questionnaire. Don't try and look at this slide, because I'm going to go through the questions because it's quite interesting. The first question patients were asked was, should patients be asked to take part in medical research? And an overwhelming amount of people interviewed, 91%, said, oh yes, of course patients should be asked to take part in medical research. They were then asked, suppose you were asked to take part in a study comparing two treatments, both of which were suitable for your illness. Would you be prepared to take part in a study comparing two treatments? Oops, we've gone from 91% to 73% of people saying yes. So the next question was usually the only scientific way to compare one treatment with another is for the choice between the two to be made randomly, rather like tossing a coin. Would you take part in a study where treatment was chosen at random? Oops, we've gone down to 55%. So yes, people should take part in medical research. Not so sure that I want to be in one of those sorts of studies myself. And if treatment was chosen at random, definitely not. So patients were then asked to see whether giving extra information might help them. The 45%, the 477 patients who either would not or didn't know if they would take part in a randomized trial, were asked to consider 3 further statements. In a randomized study, a choice would be made between 2 treatments, either of which would be suitable for you. Your doctor and experts in the field don't know for sure if one treatment is better than the other, or if they're both the same, which is why they want to do the study. Would knowing that encourage you to take part? Oh, we've got another half of them back again. The next question was, in a random choice study, if the treatment you were receiving didn't suit you for any reason, you could always leave the study. Your doctor would then give you whatever other treatment might be appropriate for you. Would knowing that encourage you to take part? Yes, we've got 64% of the previous naysayers saying they would. And then before you decided if to take part, the doctor would tell you all about the 2 treatments involved, including the side effects. Would knowing that encourage you? And yes, so together, knowing either treatment was suitable, you could leave the study if it didn't suit, there's plenty of information before the random choice is made. Would all these things together mean you'd change your mind and agree to take part? And we've got people back in, showing how important these extra pieces of information are. The majority of cancer patients, 91%, were not averse to research, but 45% found randomization off-putting. 2/3 of those changed their mind when given further important information, and overall, 83% had positive attitudes towards randomized trials. Only 6% said no, with 11% remaining uncertain. Now, we need to ensure, therefore, that our verbal and written communication is consistent and people get all these pieces of information. Sometimes people say to me, well, it doesn't matter if I don't tell patients about everything because they'll read the patient information leaflet. But many of these, even if they're written with the help of patient advocates, are still written at far too high a literacy level. It's a rather shocking thing to realise how low the health literacy and numeracy of UK populations are. Most health information is far too complex for 43% of working age adults in the UK. 1 in 4 adults are also going to feel anxious when they're given any numerical information about health. And I think this is particularly shocking when we realise that nearly 49% of working age adults have the expected level of numeracy of a primary school child. And only 1/5 of working age adults are even functionally numerate. So in the context of this, often quite irrelevant information has much more influence on those who are less numerate, who might make decisions on less complete and poorly understood information. And I think healthcare professionals need to be able to convert the numbers about risks associated with different treatments, the risks associated with different side effects. They've got to be able to discuss these in concepts that are interpretable for individuals making personal risk appraisals. So how good are healthcare professionals at this? We've run lots of different workshops over the last few years on talking about gene expression profiling tests or genetic testing for BRCA and BRCA1 and 2 mutations. And we gave all the healthcare professionals, these are senior people, not students, on our courses, a very short basic numeracy test here. You can see the questions and you can see the answers. I'm not going to be cruel enough to ask people watching to do it, but what were the results? If you see here, we've got oncologists, nurses and surgeons, and a quite shocking number cannot actually convert these quite simple basic numeracy questions into percentages or proportions or probabilities. So what the patients get from that, I don't know. So we need to do more work on that. Now, I mentioned that one of the other things that we did with Bob Suhami was look at doctors' discussions with patients about randomized trials. And this was the paper that was published. It was important background material for us for a planned intervention we had. 82 consultations by 5 oncologists were taped and analysed. In a majority of the consultations, general or personal uncertainty was introduced, but randomization was mentioned only implicitly in about 2/3, and analogies were used in 1/3 of them. Although treatments and associated side effects were usually described reasonably well, not all patients actually even received information leaflets. Now, explaining the logic for treatment options, including trials, is quite a lot to get through. The patient needs information about all options, therapeutic intent, what's involved, visits required, length of the different treatments, associated risks, harms, and putative benefits. That's why all these numbers become important. If information isn't really clear enough, patients are easy prey for the charlatans on Dr. Google, and social media generally can raise patients' treatment expectations. We know health numeracy and literacy levels are low, and many words and phrases, therefore, are completely meaningless, counterintuitive, or ambiguous. So oncologists' own communication about risk, harms, and benefits can also be subject to unconscious biases and misunderstandings. So unless we can improve our repertoires when explaining things, our patients are probably not making informed choices about their options, including whether or not to go into a trial. So when we were at UCL, we started a variety of training programs. Now, there are plenty of communication skills programs, but actually many of them show little evidence of transfer then into a clinic setting. My group have always worked around the methodologies first described by some real pioneers in communication: Rogers, Knowles, Freer, Engel, and Lipkin. All of those people in different ways showed the need for incorporation of knowledge, behavioral skills, and personal awareness in training if you were going to see transfer into the clinic. Why do we need all three things? Well, if learners know what to do, but not how to do it, then they're going to apply things in a clumsy and inflexible way. And if a learner knows what and how to do it, but sort of doesn't really believe in it or feels uncomfortable, they're not going to use it in practice either. So learner-centered methods with cognitive, affective, experiential, and behavioral components do change skills, as we've shown in this really pivotal paper published in the Lancet, that will transfer into the clinic and are enduring over time. So as a result of this big randomized trial that we did in different communication skills models, we went on to apply this to the development and evaluation of randomized clinical trial workshops. On that previous Lancet paper, over half of our senior clinicians and a quarter of nurses on other programs acknowledged that providing patients with complex information and seeking consent were their primary communication problem areas, far outweighing things like breaking bad news. So we produced an educational training program and then, importantly, evaluated it with healthcare professionals who were actively engaged in trial recruitment. And here is the paper. Now, the program, Module 1, comprised really of a generic introduction with lots of didactic components and exercises into communication about trials, collaboration, or conflict of interest. The whole program had 4 modules. As I say, this first one was a generic introduction. The second module was looking at dealing with uncertainty in adjuvant trials, a colon cancer patient in a placebo-controlled trial, a breast cancer patient in a double-blind trial. Module 3 was dealing with poor prognosis patients. This is a patient who had a nasty hematological cancer with the option of going into a study with really quite toxic side effects, and she still had a poor prognosis. And in this scenario, we saw a lung cancer patient discussing a trial that had a no treatment arm. Then module 4 was dealing with trials where patients might have a clear preference for one of the treatment arms. And you'll notice that we've changed the characteristics of the patients as well as the specifics of the trials. Here we see a prostate cancer patient who we describe as the internet guru. Believe it or not, that is the patient, that is the doctor, but the patient looks like the doctor, I think. Now, you've got to evaluate things to see if they work. We allocated healthcare professionals to 2 groups, or randomized them to 2 groups. They filled in baseline questionnaires. Then Group A had a pre-workshop role play. Group B had a pre-workshop role play. This is with a trial that they were currently recruiting a patient to. They then had a 2-hour gap when they went and walked around Brighton, and then they repeated the role play. We did this because we wanted to show that if there were improvements, it wasn't just because somebody was doing something for a second time. Then both groups had the intervention, the workshop with the training package, and lots of post-workshop role play and questionnaires. We had 101 oncologists, surgeons, and research nurses in workshops where they had facilitated discussions with those modules, lots of interactive exercises, how to structure trial interviews with patients, describing randomization, didactic presentations, and the assessments The subjective ones were self-confidence, and objective ones, researchers blinded time point checked for the absence or presence of key information areas in the role plays, and the simulated patients also completed assessments about the healthcare professionals' communication skills. I'm not going to go over these in a lot of detail, but on all of our measures, subjective and objective, we did see significant changes. Don't forget, we wouldn't expect all things to be that side of the bar. Here, the healthcare favoured one treatment. You'd hope that the doctors weren't actually favouring one treatment. But whatever it was, people seemed to be doing well, and the participants' self-rated confidence on all sorts of things went up. There were no practice effects found in Group B, so we knew that on future courses we wouldn't need to measure that. Since that evaluation, obviously there have been changes in trial infrastructure that have improved recruitment, but many people attested to the benefits of the workshops. Here are a couple of quotes. Attending a workshop such as this would benefit every new trial we open. We've seen increased enthusiasm for trials, recruitment, and team dynamics. The workshops were adopted for training in England and Wales, also in Canada, and they were dubbed for use in Germany. More than 200 facilitators worldwide have been trained, and so thousands of healthcare professionals have now actually received the training. Several organisations, including the MRC, Pharma, also asked us to make DVDs for patients explaining complex trials, which has been interesting. And we developed further modules to accompany the series, explaining screening and chemoprevention trials, explaining complex multi-arm trials, where you could argue is even more difficult for people to do. And we also did another module on pediatric and adolescent trials. So even though these trials are now very old, people still find the modules useful. Now, that was looking at individuals, but discussing trials is a serious team business these days. We did a huge study across 22 multidisciplinary teams in Wales, looking at different cancer sites. We examined the involvement of individual team members, the clarity of their communication. We used that attitudes to randomized trials questionnaire on all their patients, 50 of each team's patients in clinic, to see how they felt about trials, and also looked at healthcare professionals' own attitudes. We then ran workshops for the teams and found significant improvements in their encouragement of patients to enter the trials, their likelihood of startup meetings being attended by the whole MDT, and importantly, a recognition of the actual and potential informational roles that different team members play in trial discussions. And we increased their confidence in 14 aspects of trial recruitment and management. Now, if you're going to do this, how do you develop and evaluate an educational program? I'm going to take you through an example of one that we did for recruitment to early phase trials, phase 1 and 2 trials, a really difficult area to deal with. First of all, of course, you need to research the area yourself. We did lots of scoping exercises to look at the communication and informed consent procedures out there in phase 1 trials. We looked we continued to update this with a review of the literature to make sure that somebody hadn't already got some good ideas that we could actually capitalize on. We then conducted some field work. We looked at the reasons that patients give for participating or not in phase 1 trials. And then we tape recorded many very senior oncologists in big cancer centres throughout the UK talking to patients about phase 1 trials, And I really recommend this paper by my colleague Val Jenkins, who was the first author, What Oncologists Believe They Said and What Patients Believe They Heard, an analysis of phase 1 trial discussions. That throws up some very interesting things. So research the area, what's out there, what do we know about it, conduct some field work amongst patients and doctors and nurses talking about these things, then design a program and evaluate it. We designed a program about phase 1 trials. I haven't got time to go through it all. And then held evaluation workshops. And again, we showed that we could improve communication, knowledge and self-efficacy of our participants. That's great, but what then? One has to disseminate the materials, otherwise we're not going to show a difference. So having established efficacy, we then usually produce comprehensive handbooks and train facilitators to go out and pursue the message widely amongst others. So I want to just finally mention not so much a giant, but a friend that I so miss because he's dead now. Rob Buckman, who was also at UCL, but I knew him over the years in many settings, and we had a shared interest in communication. And he said, almost invariably, the act of communication is an important part of therapy. Occasionally, it's the only constituent. It usually requires greater thought and planning than drug treatment, and unfortunately is often administered in sub-therapeutic doses. So I'd like to thank all my colleagues, especially Val Jenkins at Shawsea, the many, many other giants whose shoulders not only myself but my team have stood upon and been able to use their knowledge and encouragement to influence the practice of talking about trials, not just in the UK, but actually in lots of other parts of the world as well. Thank you particularly, Mike Baum, for giving me my first chance to do a trial in cancer. And thank you, Bob Sihami, for making all of my team think harder about the reasons why patients will enter trials, why some will refuse, and what our healthcare professionals are doing when they're talking about these important things. Thank you all very much for listening.